45 minutes, we're going to be talking about from idea to action, making health equity a reality. Before we kind of really get into it, and I just want to tell you a little bit about who the Ladipo group is, who I am, why we're doing what we're doing. So you just have a little bit of context for yourself about who we are and what we do. I'm Tonya Ladipo, and I founded the Ladipo group in 2004. And the reason I started the company is I'm a licensed clinical social worker by training. And I was working in a lot of community mental health agencies. And I saw two things happen in different agencies. I saw people who looked like me get pretty bad mental health treatment. And I would go to management and I would say something about how like people should be treated better, we can do better. And management didn't want to listen or make any changes. Or I would work in a place where people were getting incredible like mental health services, talented clinicians, and the people receiving the services didn't look like me. And so I would go to management and say, we do great work. Can we diversify who receives our great services? And again, management didn't seem so concerned with making any change. And so that's why I started the practice. I started by myself as a Black therapist, working with Black clients. And then over time, grew the team, had other therapists join, and we really specialized in being Black therapists for Black and African American communities. And then in 2010, we expanded to do consulting with organizations because a lot of what our clients were coming to us reporting as a source of stress were personal relationships and then the workplace. And so I was really thinking if we could have a greater impact on the workplace, then we can service our community even better. So that's when we expanded to do consulting with organizations. Some of the services that we offer, we are a mental health EAP provider that specializes in working with underrepresented communities. We do workplace wellness and equity, diversity, inclusion, and belonging consultation services. And I'm going to explain what that mouthful of equity, diversity, inclusion, and belonging means a little bit later. We also work with HR departments and do audits specifically with a lens of promoting equity within that workplace. Then we do lots of public speaking and panels and workshop facilitation. These are some of the clients that we've worked with in the past and currently. And so you see different industries, right? There's a tourism industry, there's corporate, tech, education, healthcare. And, you know, when we, as our team, we're talking about how can we have the greatest impact? And healthcare kept coming up. Because when we talk about equity, the need for equity, I think, is really important. And it has incredible ripple effects when it comes to economics, education. Like there's a huge impact in other industries. But healthcare is one of the few industries where it literally is life or death. When there's equity and there are not, you know, the disparities in healthcare, people's lives are being saved. And so just that intensity and clarity is really why we really want to be able to impact healthcare and really want to not just talk about health equity, but move to achieving health equity so that people have a better quality of life and so that people are alive longer. My father is a physician, an emergency room physician, and so we often talk about work. and we were talking about prostate cancer and breast cancer because I had just heard, he knew this, but I didn't know this, that for prostate cancer, that the screening for it is really simple. It's a blood draw. And that I also had learned that Black and African American men die from prostate cancer more than non-Black and African American men, and they get it at a greater rate. And so I thought, wait, and prostate cancer is also a cancer that's really treatable, right? The curable rate is really positive. And so I was thinking, well, if is the case, if this is a really treatable cancer, the way to find out about it is a blood draw. It's really simple, yet certain people are dying more and being more impacted by it. Why aren't all Black men past a certain age, past 35, routinely screened for prostate cancer? Like, why isn't that just whether they're going to urgent care, their primary care physician, the emergency room, like at whatever place, why isn't it just automatically like given as an option? Like, let's just do this quick screening while you're already here. And so that's just like a simple like example, but it just made me think, like, how many other ways are we overlooking points of entry to really create equity? And I think something that also kind of has lingered with me, when I was 24, so a bit ago, my cousin, who I grew up with, literally she lived 2 blocks away from me. So, you know, she was 6 months older, knew each other our whole lives, kind of, we were close. She had surgery in her foot. I don't remember what was wrong. Something was wrong with her foot. She had surgery, not a big surgery, not a big deal. And ultimately died, which was shocking. And so here was, you know, a young Black woman who had foot surgery, who said she was having trouble breathing, who wasn't listened to, who was sent home and later died. And I know a lot of people who have stories like that. And so when I think of the reason and necessity for health equity is really to save lives. So in our time, I'm going to talk about really the concerns about health equity, the definition of it, the purpose of it, what health equity in action looks like, and then some next steps. And then I'm going to open it up for questions. So if you have questions, feel free to jot it down, put it in the chat, and then I'll come to it at the end. So I just want to go over a few statistics to kind of really highlight the concerns that are existing present day in healthcare. And so you see on the slide, Black and Indigenous women are 2 to 3 times more likely to die from pregnancy-related causes than white women. Black and Indigenous infants are also 2 times more likely to die than white infants. At birth, the rate of a life expectancy for an Indigenous person is 62 years. For a Black person, it's almost 71 years versus white people whose life expectancy is about 76.5 years. And then when we think about mental health, white adults who have mental health conditions, 52% of them seek the treatment that they need. And I should say seek, receive the treatment that they need, compared to 39% of Black folk, 36% of Latino Hispanic folk, and then 25% of Asian adults. And so this is just a really quick snapshot of present day statistics of what is clearly not great healthcare for everyone. And so what we need to do differently to make that a reality. Let's go to the next slide and start with a shared definition, because if you Google the term health equity, you're going to find so many different definitions. And so we chose a definition that we thought is most applicable and comprehensive, but also really succinct to what we're talking about. So for our conversations today, health equity means reducing and ultimately eliminating disparities in health and in the determinants of health that adversely affect excluded or marginalized groups. So that's the definition that we're going to use today. And I think that for yourself, for your institution, it's really important to have a shared definition to go back to, because it helps you stay focused and stay on track in terms of like, wait, what are we talking about? Why are we doing this? What are we doing? So starting from a definition that is agreed upon, I think is really, really important. Let's talk a bit about the purpose of health equity. So for our purposes today, there's 3 main points about health equity. So it's meeting the healthcare needs of everyone. not just some people. So when you think of when I explained how I started why I started the Ladipo group, because not everybody was getting great service, right? In some of the places I worked at previously. Everybody deserves and should receive great health care. And so that's the point of health equity, is making sure that regardless of your zip code, regardless of your educational level, regardless of your income level, that you have access to and actually receive great health care. So that's part of health equity. Another piece of it is really to remedy the medical exclusionary practices that have existed in Western medicine. And so when we say medical exclusionary practices, that's the idea that research on certain diseases, interventions, treatment, signs and symptoms historically has been conducted on some populations of people. And then that has been extrapolated to say, like, oh, this works for this population of people, it's going to work for everybody, when that's not true. And so an example is when you think of heart attacks and heart conditions and heart disease. Historically, a lot of the research on the signs and symptoms of heart disease, the interventions and treatment for heart disease, have historically been done on white men, and then found effective treatments that have worked for white men, and then have said, oh, this is what is true for everybody of all races and all genders. Yet later realizing that people who are not men, people who are women might have different signs and symptoms, which means that issues get missed, or the treatment might not work the same based on gender. And so that's when we talk about medical exclusionary practices, remedying that. So making sure that everybody is included in the research and the treatment design, so that we know what works for who, or different things are going to work for different people, right? So remedying that. And then also addressing and correcting medical abuse. You have to know where you've been to know where you're going, right? And so health equity is really correcting wrongs that have been done. A lot of people are familiar with the Tuskegee experiment, where they intentionally injected Black men with syphilis to see the progression of the disease. I think what might be less known, but is also just as horrific. So modern gynecology, really, in the 1840s, a lot of the kind of understanding, treatment methodology, procedures came from performing experiments on enslaved Black women in the US. And so doing procedures without their consent and without anesthesia has been kind of the history of gynecology. And so just the way that connects to today, if enslaved Black women were having procedures performed on them without anesthesia, and some were able to survive, it is unimaginable. And some were able to survive. The idea of like, oh, well, then Black women must not experience pain. They must be able to do this without pain medication, right? That kind of thought process then kind of gets passed down. And if you look at modern day research, it actually confirms that a lot of healthcare professionals will incorrectly assess the pain level of Black people, and say that they need less pain medication, have less pain than they actually do. So that just to know where we've been and know what needs to be corrected, and to know what needs to be corrected and know why some communities are resistant and are rightfully hesitant to engage with the medical community because of the history. California actually gave financial compensation to women because there were a lot of Latinas in this country who were forcibly sterilized. It's unimaginable, and very much part of the medical history. And so part of health equity is correcting the harms that have previously been done and caused, and then looking at current policies to ensure that never happens again. So that's a really important part of it. We can't talk about equity or health equity with also talking about the elephant in the room in the current climate. I think with the Supreme Court ruling on affirmative action, there's a lot of concern about how that's going to impact medical schools in terms of how they may diversify their medical students, which has a significantly positive impact on patient healthcare and outcomes. There's been a lot of, I would say, stigmatization of language when we think about diversity and equity and inclusion. Like those have become, I don't know, trigger words for some people, kind of as a red flag of like, oh, there's something not good going on here. And then also I would say kind of the politicizing of healthcare. When healthcare, I will say healthcare is a political issue because there are federal laws and federal funding that are very much connected, right, to healthcare. But it's not a one-party issue. It's a bipartisan issue, right? Healthcare is about every single person in every state, whether it's a red state, a blue state, or purple state. Every person deserves great healthcare. But I did want to kind of mention, I know we're talking about equity in a climate that is I don't know if I want to say uncertain, is more tense. It is more tense. And so I do want to give a little bit of real flavor to some of those words that may cause some people pause, just to bring some life to them and to destigmatize them. And I just want to give a sense of what is actually diversity, equity, inclusion, and belonging mean. And so I'm going to use a metaphor that Renee Myers, who was the former chief diversity officer at Netflix, gives a great metaphor to kind of give understanding to diversity, equity, and inclusion. And so think back to a high school dance. So just imagine that for a minute, a high school dance. And so diversity is when you're invited to the dance. Not just certain people are invited to the dance, but diversity is where there's a lot of different people are invited, right? Everybody gets invited to the dance, regardless of their race or their age or religion or sexuality, gender. Everybody gets invited to the dance. That's diversity. But you could be invited to the dance and then sit there, right? And maybe only a couple of people are dancing. And so inclusion is really, you're at the dance and you're being asked to dance, right? Everybody is like asking each other to dance and engaged in the event. Equity is organizing the dance. So it's not just showing up, but you have a key part in deciding where the venue is, what the music will be, what the food will be. That's equity, which is why we really highlighted like being involved from the beginning. And then the piece I added to Renee's example is belonging is being engaged at the very beginning. So before it's even decided that it should be a dance, you are belonging to an institution. You have enough say and confidence to say, I don't know if it should be a dance. I don't know if that's the right activity for what we want to do. So that's just a quick rundown of equity, diversity, inclusion, and belonging. And I want to apply that to healthcare. So diversity is the representation of patients, employees, and leadership. So that you're not just servicing a couple of populations, that there's a lot of diversity by race, age, gender, sexuality, religion, for patients, employees, and in leadership, right? That would be diversity. Inclusion would be obtaining input from all of those different perspectives. And then in healthcare, equity is what we're talking about, how to reduce and eliminate the health disparities that exist. And then belonging is really how patients and employees would feel cared for, right? And so there's lots of patient satisfaction surveys, and there's employee satisfaction surveys too. And we do know that burnout is really, really significant for healthcare professionals. And so tending to their needs to minimize that. And we're actually going to do a session on that in a week. So you'll have all that information as well. So really want to focus on, I talked earlier about knowing our history so we can know our present and know the future. And so that's when we're talking about health equity. What are the ultimate outcomes that we want to achieve? Like, why are we doing this? Decrease patient mortality, right? I gave statistics earlier that the infant mortality rate for Black and Indigenous folks is higher. The lifespan expectancy for Indigenous and Black folk is lower. So it decreased patient mortality rate. Risk management is another piece of why health equity is so important. So I'm going to start with the top, like we save lives. That to me is the most important thing. But also from an institution's perspective, when there is more health equity, you've accounted for the ways to minimize risk, which leads to a healthier organization, right? So actually, a couple of thoughts about that. Cedars-Sinai, actually in California, I believe, is facing a federal probe into their treatment of Black mothers, Black birthing parents. Because in 2016, a woman died, Kira Dixon died after giving birth. Her husband actually saw that there was blood, I believe in her IV, and kept alerting staff, and they didn't do anything, and she ultimately died. And so when I say risk management and decreased patient mortality, if we have processes and procedures in place, and we have trained staff who will listen to every patient regardless of how they look, and regardless of that own person's biases, we reduce patient mortality. Kira might still be alive, right? There's less risk for the institution that is now facing a federal probe into all of their practices because of her death. And then obviously there's increased patient satisfaction when people are getting the treatment that they need, which for institutions can lead to increased revenue when you have more patients coming in. And so, people feel differently when you talk about healthcare and revenue. But it's kind of like the elephant in the room, I think, to ignore it when it is important to some people. Like, it's important to stakeholders and the board to keep the institution running. That when you have health equity, you also do have increased revenue. And I do want to share a story. I was talking to somebody who works in the pharmaceutical industry, and she was telling me, it was really interesting to me. She was telling me that they are starting to get inquiries from some of the people they do business with. They're starting to get inquiries from them about how well medicines work on different races and genders, and have the treatments that they're developing been tested on different races and genders. And so what was interesting about that is because at that level, they were saying that there's nothing official, but the fact that those questions are coming is alerting them to the idea that at some point, this is going to become a requirement, that interventions are in the testing phase, in the research phase, tested on a wide range of demographics so that they can ensure that it's effective for a wide range of demographics. And that, in their opinion, if they don't have data to prove that they have been involving different populations through the research process, they don't think that some of their drugs are going to be funded as a result. So I just thought that was really interesting. And another way of like, okay, so here's not like where money comes in, but where health equity is like, if they're not practicing health equity, they're not going to be able to service as many people because people are not going to pay for their drugs. So I just thought that was kind of an interesting way of seeing how like this is starting to take effect. And will probably progress in the coming years. This is a bear to address. I think I want to be really clear about that, right? Health inequities did not occur overnight. And it did not occur in isolation. It's not like one person made it and that's what we're dealing with. But it has been kind of systematically built into the system. And so part of what we need to do with healthcare is while the plane is flying, what needs to be changed, right? Because in my opinion, dismantling an entire system that is about saving lives, I don't see how that works in reality. But that need to change systems while it's still operating very much as possible, right? And so how do you let go or change what isn't working and what has caused harm and keep what works really well? And so I think that's where a policy review comes into place, right? Like identifying what are the inequities in policies, and it's not on the slide, but also in practices. You might have great policies, but if people don't follow them, to know the real practices. So my guess is you know, the case I said earlier with Kira Dixon, she died and there was blood, I believe, in her IV. My guess is that there's a policy against that that's already in place, right? My guess would be that they have a policy for that. But if it wasn't followed, and if it wasn't followed because somebody was being dismissive of a Black person, right, that's what happens in practice. And so being able to identify what's in policy and practice that is inequitable and is not working and is causing harm, that's the first piece to it. Then you have to change those policies. And then you have to create accountability, which often gets missed. Like, who is ultimately responsible for this? And sometimes money is a motivator. So whose job is this to ensure happens and continues to happen? And what happens when equity is not achieved? And then you have to train staff on new policies and procedures and implementing practices. So those are the steps that are needed. I want to give a quick checklist, which we can make sure you get out, because I'm mindful of time. I want to be able to answer any questions. So when we are talking about creating a plan, we want to make sure that they're actionable, right? So if you go to the next step, what we want you to do at the end of the session is to use our checklist that you can review against your institution's health equity plan. So we have a checklist of like just questions. Like, so I want you to ask for your institution's health equity plan. What is it? Can I see it? Can we talk about it? And then just line it up to our checklist, which essentially is like, what's the plan? What are the dates for achieving the goals? Who's accountable for it? What are the financial resources built into it? So is there a budget to implement to make this plan actually become actionable? So we'll make sure you have the checklist that you can look against your institution's equity plan. And if they don't have one, that's really great information. If they don't have one, then you say, okay, so what are we going to do? And you can go big or small, right? And so this next step is, what's one thing you can take and you can measure for the next quarter? And so you can do that individually on your own, or you can do it with your health care institution. So I'm going to give you a quick one for example, and again, it depends on your role. Like it's so dependent on your personal situation. But let's say you're a nurse practitioner in a clinic. So one action would be to talk to your team and say, hey, can we, for the next quarter, can we just test out doing prostate screenings for every Black man over the age of 35? With their consent, of course. But can we just like test that out and see how that goes, how it goes for our process, how many more positives we are able to flag as a result? It's a quick blood draw. Can we do that? So that's just a quick example that you can start really small to really put things in place. We would love to be able to hear from you and get feedback from you. So we have a quick evaluation link, because thank you, and thank you. It's in the chat. So you can take the survey. You can let us know what you want more of, what was really helpful. So if you don't mind taking that survey, that would be really fantastic. And we do have some resources, but there's actually more resources than you'll see on the slide. So we have your email addresses. So what we'll do is we'll make sure we send out all the resources to you, so that if you want to do deeper reading and learning, that you can. I want to encourage you to come join us next week when we do our second part, where we're really going to talk about minimizing burnout for healthcare professionals. I have to say that in my work before the Ladipo group and doing a lot of community mental health, the amount of vicarious trauma that you witness and hear and experience is significant. And so really just wanting to be able to do a give back on ways that you can minimize that when it's a job hazard, as I think it is for many healthcare professionals. So thank you for joining us. You have a few minutes back in your day. So what I hope and what I'll recommend is, rather than rushing off to your next thing, that you just take that few minutes to yourself, since it was a gift that wasn't expected, and don't jump into email, but just give yourself a few minutes to be. Thanks for joining us.